There we go.
It's not showing on mine. Does it show on yours?
Yes.
All right.
No, now it's not. Okay, now it is.
Now we're in business. Okay, so here's who I see. I see Eric Bookbinder, Jeff, Jim Harrington, Mark Mooney, Barbara Mooney, Sylvester Mann, Jake, Peter Kafka, Dave Holberg, Professor Bill. Anybody else that I've missed?
Don Price.
Don Price, of course. How can I?
He's staring right at you.
Okay.
And I believe you missed Sylvester.
I got Sylvester. I mentioned that.
Okay.
Did you get Dennis?
Dennis Correa on the phone.
Oh, Dennis Correa's on the phone. I didn't get Dennis Correa. Hey, Dennis Correa.
Thank you.
Next week, Dennis, we'll get together. I'll be back in Tubac on Thursday, and so we'll make a plan for next week. God willing.
Sounds good.
Okay. So I think there are a couple of people who haven't been on the call before. Jeff, which Jeff is this? We have several Jeffs.
Tom's brother.
Ah, okay. So that so that is GEOFF, Jake.
GEOFF.
Okay, so Jeff's been on before. So the only people that have not been on before are Mark and Barbara Mooney. And so what we normally do is to kick off with giving you some time to talk about your situation, if you're comfortable doing that. Give us your background, and then from there we can see if we can help you out. And, we'll spend about 20 minutes to half an hour talking to you, and then we'll move on and we'll see who has things they'd like to talk about today. So would that be okay with both of you to just talk to us a little bit about your situation?
Can you hear us?
Well, I can hear you now.
Okay.
That's fine with me.
Can you hear Mark?
Yeah.
Oh my God.
What's happening probably is Mark might be on the computer, and you're on.
No, I was on a cell phone, but I switched.
There's two of you on a cell phone, and you're too close to each other. I don't want to get into family relations here, but we're getting the feedback between the two of you. So maybe you can mute, and if you can share one phone to speak through, and then listen through two phones is fine. But that's why we're getting that reverberation.
All right, sorry about that. We'll get that taken care of.
So the floor is yours.
All right. I'm 66. I've had prostate cancer since I was 55. I've had the surgery. I've had radiation a couple of times. I've been on Lupron for a couple of years. I've taken all the drugs. In October, my doctor told me that it had moved into my spine and my hips and my pelvis and some lymph nodes in my neck. At that point, he estimated I had about 2 years to live, which is what you see in the literature for that stuff too. And so around that time, I started on chemo. And I've had it's brought on a lot of other issues. I mean, those side effects, which everybody knows are worse than the treatment or worse than the cancer. I've had ulcers. I've had just continuing digestive issues. There hasn't been a day in the last 6 months where I haven't been nauseous. During the last radiation, I got radiation burns in my esophagus, so swallowing has been a problem for the past 3 weeks or more. And I find the chemo really unpleasant to deal with. I mean, in the 10 days after chemo, there's always some really serious episodes of discomfort. And frankly, I'm at this point right now where my next appointment with my doctor, I want to talk to him about discontinuing chemo. I mean, is this worth it? The daily paralysis and misery and unable to eat or drink and is this worth extending by 30% how many weeks that might be? Is it worth extending this for that? And I don't know if you guys have experienced this or you have answers about this, but that's the prime thing in my mind right now.
Well, rather than my talk, because what you say we've heard men before, I'd like maybe one or two of the guys that have been through chemo. Eric had a really rough time, and he also thought he's seen a fairly short horizon, but thank God we keep extending the horizon for him. And let's see who else has done chemo. Don, didn't you do chemo?
Dennis did, didn't he? Dennis?
Yeah, I did chemo with Dustexel.
Are you muted, Mr.
Dave
Price?
Albert's done chemo too.
You are muted.
Dave,
I'm
You are
shaking my
muted.
head. No,
We can't hear you.
I am. Correct. Correct.
The
answer is no.
I can't hear you. Sorry. No. I don't know what's going on, but we see your lips moving. But when we figure out, no noise. For those of you who are wondering what the heck I'm doing, we have, if you join online, we have visual icons, so we can see each other. And some of you don't have the icon switched on, but you don't have your camera switched on, but you can see four of us right now. And we have
Anybody else hear me?
picture of Mr. Price moving his lips, but we don't hear it.
Can anybody?
I can hear you.
Okay. Can anybody else hear me?
Yeah.
So,
Rick, I can
let me
hear
go
him.
to Eric first of all.
I think.
So maybe
I think
you'll figure out what's what. I
Rick,
think you might be muted at your end. You're not muted at our end.
No,
Little
Rick,
green-
Rick, I can hear him,
a little
so you can't hear
green
me
bar
either.
there. So Eric, can we hear you?
Doesn't sound like it.
No, we can't hear Eric either. We're not doing very well.
No, Rick, I can hear Eric and I can hear Don. I think it's on your problem. You're having a problem.
Can we hear
That's
Eric?
the problem.
I can hear Don too. This is Bill Burns.
Yes, we can hear
Maybe
everybody.
the problem is that
You
I'm not getting it. I can't see.
Exactly. You want to have Eric and Dennis speak up a
Peter,
little
I'm
bit?
going to hand over to you because I'm not getting any audio.
Okay, Eric, do you want to talk to Mark and Barbara about your experience with chemo?
Okay. Yeah, so I had a bone scan and a CAT scan, and they both came up and said everything was fine. But my neck was hurting, and it was hurting in such a way that I knew something was radically wrong. So I kept insisting, and then they did an MRI on my neck and found I have Met C7. And I had a lot of pain, and so I immediately went to the Red Onc, and they set me up for radiation. So I'm all done with it. They only did 5 sessions. They did them every other day. And I'm feeling the fatigue now. The pain is much, it got worse first, and then they gave me steroids, and then it got better. And it still comes in off and on.
Can I interrupt you? because we'll come to you and we'll talk about your situation, but I really would like to focus on chemotherapy and your experience with the chemotherapy for Mark.
Oh, I'm sorry. Yeah, I missed that.
Yeah.
I had an emergency call on the other line. I was off for a little bit.
Right.
Yeah, so I had chemo, docetaxel. I had it 6 sessions, 3 weeks apart. I got very, very sick. I didn't eat for a week. Food, everything I tried to eat tasted like bad cardboard. Not even just cardboard, but bad cardboard. And I lost about 40 pounds. But it was only 6 sessions, and I do feel I benefited from it. I've been on, a few other drugs, including, and I was on a trial drug that worked for about 9 months, and then the 10th month, that's when I got this net in my neck. But I do chemo again, and they're talking about doing it again, just because I know it was horrible to go through it, but relative to the time that I'm going to stay alive, I had a few months of discomfort, and I think it, probably added 10 months, maybe a year to my life. So I feel it was worthwhile. I mean, as I said, if, the side effects were awful. If I'd had, 15 sessions, I probably would have withered away to nothing because I was losing weight pretty fast. But I've gained all the weight back and then some. So I'm relatively healthy. That's my experience. That's what I have to say about it. I know that the side effects are awful, but as I said, I would do it again.
Dennis, why don't you talk a little bit about your experience with chemo?
Sure. Yeah, I was diagnosed, finished my chemo about a year ago, and I had been diagnosed about a year before that with metastatic prostate cancer and lumbar spine to start the androgen control there. And I had problems about, similar to you, after getting the chemo, the day before I'd start with was it prednisone, I think it was, and then the day of and then the day after. But then you start to slide after down to about the 10th day or so. The white blood cells were getting pretty low and feeling lousy and, hard to eat. What I did find eating something, the only thing that seemed to be any good was butterscotch pudding with a plastic spoon. I could actually taste it and didn't get the metallic or the cardboard taste with it. But anyhow, partway into my chemo, I was starting getting severe chest pains. When in the emergency room, they admitted me, and after several days, they diagnosed me with multiple pulmonary embolisms in both lungs, and put me on some morphine for a day or so to help with the pain that I was getting. But that was my absolute low point, and thinking that, is this really worth it? So you're not the only one to have that kind of thoughts. And if this is going to be what it's going to be like, just take me now. But we got through that with, they treated that. They treated my pneumonia, which I had also contacted, and then reduced my dosage by 20%. And they also added the Neulasta. That's the day after shot type thing, right, which really seemed to help. And I was able to complete my course of the chemo. And then things did start to, I had some, I had to take blood thinner. I had to take daily injections in the abdomen of a Lovenox blood thinner to help with the blood clots. And eventually, I think it was several months of that, and that finally a blood test showed that the debris had cleared up in my blood and the blood clots had all redissolved. And so I was able to get off the blood thinner and resume my normal physical activity. So I'm 71, and I would do that again. I think I made the right decisions along the way with what I did. At this point, I'm not sure if I go through a second bout of chemo, but I would definitely do the first one.
And how long ago was it you had your chemo?
Last year, about the same time. I was just finishing it up. Let's see, would have been, I think, the end of July I finished last year, 2016.
Yeah, by the way, it's Eric. Mine was, I finished 2 years ago.
Let me just touch base with Don, and then I want to just come back and ask these guys a couple of questions, and then we'll maybe get some crosstalk going between all of you. But Don, you did do chemo, didn't you? No, you didn't.
No.
Okay. So is there anybody else on the call who has done chemotherapy other than Eric and Dennis today?
Dave Halbert's done chemotherapy.
Okay, Dave.
I had 9 sessions of Taxotere. One thing that was just popped in my head is during chemotherapy, I was not on Lupron. So I don't know if that has any bearing or not, but I literally, it was very successful, 40% reduction in PSA across the time frame, consistently, and no major side effects. I wasn't affected by eating. I would have strange things happen to my body, and I was obviously, tired, but I would just take naps and do take a nap and get up and go. So I didn't lose any weight. So I don't know. That was my experience. And then obviously afterwards, then I went into Xtandi and Lupron after that. But during the chemotherapy session, I didn't have major issues. Obviously lost my hair. I don't have much hair, but I lost all of it. But
what was the drug? It wasn't docetaxel. You said something else.
Docetaxel. It was docetaxel.
It was.
Yeah.
Well,
or Taxotere.
I don't know.
Mark, it's sometimes referred to, as you probably know, as Taxotere. Just a couple of quick questions for you. I know you live in New Jersey. Where are you being treated, and who is your doctor?
it's Dr. Michael Morris is my main doctor at a Memorial Sloan Kettering. More and more of my treatment, he's in New York City, but I'm moving all my treatment out to Baskin Ridge because I just find it grueling for me to get into the city anymore.
I mean, we know of Michael Morris pretty well. We've had a couple of other guys that have seen him over the years, and he certainly has a great reputation. And the guys that I know that have seen him have enjoyed the relationship they've had. So, it doesn't get much better. At the same time, that doesn't mitigate the fact that you're having such a tough time with your chemo. A couple of things. I mean, are you taking the nausea? Are you taking any sort of antiemetic right now or not?
Very little. My experience with meds is there's always a side effect, and it's always something you don't expect, and it's really nasty. So I'm kind of leery of any more drugs in me. I have some Zorfan if I need it at times. I have oxycodone. They gave me this stuff of lidocaine and some other stuff for the radiation burn, but I use it all very, very sparingly because sometimes it just makes me feel worse.
So let's just stick on the nausea for a second. I mean, there is a drug, Zofran, which a lot of guys have used and a lot of guys have benefited from. And I don't know, I don't have the side effect profile up with me, but I think that most of of the people I know that have taken it haven't really complained, and it's something that's worth discussing with Morris.
Well, I have Zorfan,
Okay.
Zorfan, or whatever it's called.
Right.
I've used it several times. It's worked a little bit on one occasion.
Right.
On occasion, I just felt awful with it.
Right.
So,
anybody that the other, and I don't know whether it's available to you, but if it is, I would urge you to look into it, is that cannabinoids can be very effective as an antiemetic, as an anti-nausea drug. And again, I know a lot of people that have found a lot of relief, but it has to be the right cannabinoid. It's got to be CBD weighted, high CBD, low THC. But it works for a lot of people, and you know it's relatively innocuous. I don't know what the situation is with medical marijuana in New Jersey. It is a really good solution, not just for that, but some of the other pain issues that you're going through. And again, if it were me, I'd be looking at whether I could get it, and if I tried everything else and I was worried about what I was taking, you might get some relief. As the guys who have been on, there are 3 of you that have been on chemo. What have you taken to address some of the issues that Mark is wrestling with, like the nausea, like the inflammation, the burning, etc., etc.?
This is Dennis again. My nausea was not all that bad, but I was having a lot of bloating, abdominal bloating, and lower end issues. And my supportive care doc recommended a probiotic, which is called Vital 10, VITAL-10, manufactured by Claire Labs, Klaire. And that has done wonders for me. I am continuing to use that, and I have not any, the bloating has gone away, which probably related to the chemo, but I just like it. It keeps me very regular. Don't get any abdominal cramping and stuff like that, like I was getting.
Mm-hmm.
This is Eric. I went the medical marijuana route. One time it worked, and the other 5 times it didn't work. So, it was a miracle the time it worked. It was, came in the form of candy. I ate it, and within an hour, I felt normal and I could eat anything. But as I say, it was only once, and the problem, is that there's no controls on it. So it could be that, that was the only one that really had CBD in it. I don't know, but they kept bringing me in to hydrate me. They said I was dehydrated. I don't know if that made a difference, but they put me on IV and pumped me full of D5W or whatever, and I didn't take much else. Was on steroids the whole time, so they gave me prednisone every day, and then the day before, the day of, and day after, I had methylprednisone or one of the other ones. And while I had that steroid, I felt fine, but as soon as I went back to the regular prednisone, I was off again. I didn't try much else. Go ahead.
Did you take the prednisone more than
every day?
You took prednisone every day?
Every day. And then they gave me a stronger steroid for the day before, day of, and day after.
Huh. I have prednisone, but he tells me not to take it.
Yeah,
I even said maybe I should take a steroid. It'd make me feel better. He said, no, stick with the oxycodone.
This is Dave speaking. I had prednisone 5 milligrams every day. And then for nausea, I took GRANISE Tron, Tron. But I had a prescription, but I used it hardly at all.
Why was that?
Didn't have nausea.
Oh, okay.
Who was that was just speaking?
That was Dave Hulbert.
Oh, Dave Holberg. Sorry, Dave. I thought I was supposed to have recognized your voice, but I didn't quite make it that time. Sorry about that.
Yeah, prednisone was every day.
Okay.
5 milligrams.
Okay. You know, Eric went back onto a steroid to deal with some issues you were having as well. What were those issues, and what steroid did they put you back on?
Well, after I had 2 sessions of radiation, Tuesday and Thursday, and then I went the entire weekend, and it was Monday before my next one, and I had a huge amount of pain over the weekend. And the Norcos and the oxycodones didn't touch it. So when I told my rad onc that, he said, what happens is that the cells will swell as they're dying, so then it gives more pressure on the spinal cord. And so he gave me methylprednisone. It comes in a pack, and you take 6 the first day, and 5, and then 4, and 3, and 2, etc. So, you know, it's kind of shocking at the beginning, and then you taper off. And within a day, I was no longer feeling the massive pain that I was. It helped a lot.
Mm-hmm. A couple of thoughts that I have, Mark, for you to discuss with Dr. Morris. One is the approach that Dennis took, where they reduced the amount of chemo, which seemed to help him a great deal in terms of tolerating the chemotherapy. And once they reduced, and I've heard this with other people, they reduced the dose a little bit, and some men do lower dose. So that's one thing to raise with him. The other is that since you're having such a rough time with docetaxel, maybe to try the sister drug, cabazitaxel, which is also called Jevtana. You've probably heard of that, which has an easier side effect profile for most men, not for all men, but for most men. And to have a discussion with Dr. Morris whether you might be a good candidate for trying cabazitaxel. What has your, since you on the chemotherapy, what's happened to your metastases and your PSA and your markers and your ALP, your alkaline phosphatase? I mean, are you getting any results from the chemo?
The PSA I know has gone way down. I don't feel my lymph nodes anymore. But my spine, I don't think it has retreated or anything. In fact, I think it moved a little further higher. Because originally they were going to do the radiation recently on my lumbar, but they had to move it up to the thoracic part of the spine. It has advanced. So I'm getting an MRI week when I'll know more then.
I'm sorry.
I do know the PSA has gone down.
Could you just repeat that? Because I'm using a very small tablet and I'm just having a lot of problems with connection right now. Could you just repeat what you said about the MRI and the PSA?
The PSA has gone down significantly.
Okay.
I don't know that it has retreated at all in my spine. In fact, I suspect it has advanced because my recent radiation was supposed to initially concentrate in the lumbar region and they had to move it up to the thoracic region, so it's higher.
Right.
I don't know what else I don't know what else I had to say.
You were going to say something about an MRI. You're going to have an MRI or something?
Right, I'm getting an MRI next week, so I will know better after that.
And what's the PSA done?
I don't know what the exact numbers are. Frankly, I stopped looking at them. But the doctor had told me they went down. I think they were in the 60 range, and I think they're in the mid 40s now.
Okay. Well, you know, it may, if the chemo is curtailing the cancer, if it's reducing the cancer, which it may be, I do think it's worth talking to him about, you know, either reducing the dose a little bit or trying cabazitaxel, because these are things I know have worked for other men. And obviously your life is miserable right now because of the side effects, but you know, if we can pull those side effects down so it becomes more tolerable for you, it may be beneficial. I don't know if Bill Burhans is still on the phone. Bill, are you still with us? I saw you hung up. Did you come back on? Guess not.
One thing that I heard these other gentlemen say was it seemed that their lives got extended more than a few weeks or a couple of months.
Right. And you know, let's talk to, I mean, we've got people on the phone who are well past their sell-by date. So, you know, the doctors say to you 2 years, but that's a pretty, it's a pretty coarse estimate, because some people don't last very long and some people last a lot longer. I mean, anybody want to talk about being around now when they didn't expect to be?
Well, this is Dennis again. When I had got my diagnosis and I was in the process of making the decision about my treatment, what I looked up and found that for a person in my situation, with the initial diagnosis being metastatic, that the average life expectancy was about 9 months. So I've beat that for sure. By quite a bit. And one last thing, I did find what I was using for nausea. It's called Compazine.
Mm-hmm.
That's the brand name. It was Compazine.
Right. That's another alternative to Zofran. Again, works for some, doesn't work for others, but something that's worth discussing. You also might want to talk to him about whether you should be getting Neulasta. I don't know how your blood counts are. Is your blood work pretty solid, or is it not looking so good, Mark?
No, they seem all right with that.
Okay.
They haven't raised any concerns about my blood count.
Okay. You get a pretty good idea of what we do in this forum. I mean, we've got a lot of knowledge between us. We have a lot of ideas, and we can come up with suggestions for you to raise with your medical team and things that have worked for other guys. You know, we've also got some guys on here who have been living for many years with metastasized disease. I mean, Jim Harrington is certainly one. Dave Holberg. I mean, Bill Burhans. We've got a lot of guys, and Jake. There are a lot of guys that were diagnosed with metastasized disease, and they've been around quite a bit longer than 2 years, and some of them with a lot higher PSA initially. So much of this is just trying to live in the moment and adopting the right attitude, because the healthier you feel in your head, the more successful the treatment's going to be. I personally am convinced about that. We also encourage, as counterintuitive as it sounds, especially going through chemo, we encourage people to exercise, because we know, and there's evidence, that even if you get out for a 10-15 minute walk every day whilst you're on chemo, it's going to help you an immense amount. I forget who it was a couple of weeks ago who said they were so grateful for that advice because it made them feel so much better. I don't know what you're doing in the way of exercise, but just to get, I mean, there are doctors who actually administer the chemo whilst their patients are walking on a treadmill. And there are a lot of reasons for that. And if you're interested, I can give you some stuff to read on it or to listen to. But having said that, it is important. And maybe it's the last thing you want to do, but it's the thing that might well make you feel a lot better. So with that, I'll let you say, if there's anything else you'd like to say. We hope you'll come back. We hope you'll keep listening to us. And Barbara, we have a caregivers forum, which we would welcome you to. The next meeting for that is next Tuesday. So, if you want to unburden a little bit, that's a very good place to do it.
And how do I tune into that? Maybe you can email me and let me know.
Yeah, I'll make sure. I know I have Mark's email. Do I have your email?
Barbara, I think I have the caregiver thing.
Okay, great. Thank you.
Because what we'll do, I mean, I can submit Mark's email. It'll just come to him, the reminder. But I can make sure that you get onto the email notice for the caregiver group.
Okay, I'll send you a quick email after this call.
Super. If you do that, that'll be great. And then I'll pass it on to Renata and we'll make sure that you're on that. It's going to be, let's see, I think that's the third Tuesday. It'll be at 8 o'clock Eastern time.
That's correct, Rick.
Yeah. 8 o'clock Eastern time, and you connect exactly the same way you connected today. But send us your email.
Okay.
All right. So
Thank you, guys. Appreciate the help. I'm going to mute my phone.
Okay. All right. I'm going to just run down. Let me just first of all run down and make sure that I've got everybody that's I've got a list of everybody. I think I do, but I'll go through and check and see who'd like to take some time. So we've got I've got Dennis Correa, Eric Bookbinder, Jeff Dreyer, Jim Harrington, Mark Mooney, Sylvester Mann, Jake Hannum, Peter Kafka, Barbara Mooney, David Holberg, Bill Burhans, and Don Price. Anybody that I missed? Oh, Larry Fish, excuse me. Anyone else that I've missed?
Paul Hobson from Melbourne, Australia.
Hello, Paul Hobson.
G'day, guys.
My condolences about the cricket team.
I didn't hear what you said.
Was that by choice or was that by design or by choice that you didn't hear what I said? I said my condolences over the cricket team.
No, it'll all change about Christmas time.
Okay. All right.
For everyone else on the call, Rick suddenly become patriotic Brit, and the Brits unfortunately whopped the Australians in an arcane game called cricket.
Well, I must.
And he's rubbing it in.
Just forgive the rest of you. Just forgive me, but Paul, I was at the Oval last Monday, and there must have been 30,000 Bangladeshis and maybe 3 Australians, 2 of whom were sitting right behind me. I don't know where you guys all were. You got plenty of Aussies in London. Nobody showed up to support your team. I see.
No comment.
I'm left him speechless. All right. Anybody else that I've missed? All right. So let's go down and see who'd like to take some time. We've got a little over an hour, so we've got good time. First of all, I'll start with Dennis. Dennis, was there anything you'd like to say today?
Yeah, I got some questions about genetic testing.
Okay. Eric was in view and now he's out of view, but I know Eric wants to just...
I'm still here.
I see him too. He's walking over with a cup of coffee. Eric, I'm putting you in. Give us an update on what's going on with you. Okay?
Yeah, okay.
Jeff Dreyer, would you like to talk a little bit today?
Yeah, I have a meeting coming up, but yeah, if there's enough time.
We'll put you on first. Jim Harrington, anything for you today?
No, thanks, Rick. I'm fine. I'll just listen.
Okay, Sylvester, anything for you today?
Not this time, thank you.
Thank you. Jake, anything for you?
No, nothing for me.
Okay. Peter, anything you'd like to talk about today?
If there's time, I wouldn't mind revisiting that discussion we had last week of the benefits of early Zytiga versus the idea of early chemo. What do you think on that?
I have some notes. On that. So yeah, we'll try and allocate some time because there seemed to be quite a bit of confusion about the study last week, and I think both Peter and I are a little clearer on it this week. Dave Holberg, how about yourself? Would you like to talk today?
I think I'm just going to listen. I would be interested. I know early Zytiga, I took Xtandi and was very successful with that. So that's maybe.
Okay. Then Bill, you're back with us. Would you like some time?
I'm sorry?
Would you like to talk to us today about anything?
Yes, if I can do it soon. I'm going to have to leave again fairly soon.
Okay.
But that's okay if you'd rather, you know, I will be back next Monday.
No, I definitely want to hear from you. So we'll go to Jeff and then we'll go to you. Okay?
Okay.
Or you can let Bill go first.
Okay, Bill.
Bill, you go first.
We'll start with you. Don Price, anything for you today?
No, I'm okay, thanks.
Okay. Larry Fish, anything for you? Larry, are you with us still?
Yes, I'm here.
Okay. Anything you'd like to talk about today?
Are you talking to me, Bill?
I was talking to Larry Fish.
It's, I don't know, it seems like I'm muted or something. Oh, I didn't have anything special. It's Larry Fish. I'm okay.
Paul, hopefully you'll be with us and you can give us a quick update. Paul?
Was you talking to me in Australia?
I'm talking to you in Australia, yeah.
Yeah, no, look, I'm just listening today, thanks.
Okay, well, we may just check in with you to see how you're doing. So let's start with Bill. Bill, tell us what's going on with this pain pump and what's been happening and
okay.
Found that has helped you in the last few days.
Okay. Hold on one sec, okay? I'll be back in 10 seconds.
Okay. This is where we usually ask Jake to give us a song and dance and a musical interlude.
Okay, so
go ahead.
I'm sorry that I left there briefly, but is Mark still with us? It looks like he is.
Yes.
And I just wanted to ask Mark, you're really quite young to have prostate cancer, and that often can mean that there's a genetic component to it. So I'm a cancer geneticist. I work at one of the National Cancer Institute cancer research centers. I'm a senior scientist. So I just wanted to quickly ask you, have you considered or have you had any kind of genetic testing?
I hadn't considered it. There's no history of it in my family. At least not that I'm aware of it.
Okay, it might be worthwhile to just talk to a genetic counselor at Sloan Kettering. I don't know if there has to be one at Basking Ridge, and certainly there's one at Sloan Kettering in Manhattan. But even even if you don't think that you have a family history, it might be worthwhile talking to them to see whether or not genetic testing would be worthwhile in your case. If you are tested and it turns out you have a mutation that is promoting your disease, which is the case for me, then it actually opens the door to other types of treatment that can be quite effective. And they're not, I can tell you from my own experience, they're not nearly as difficult to deal with as chemotherapy is. So I just wanted to let you know that before I went into my story. So on April 21st, I had an intrathecal pain pump installed.
Bill,
so it's a hockey puck size.
Bill,
Yeah.
can I just add one comment to that before we start on the pain?
Sure.
Well, there are two types of genetic testing. One is to see if you have an inherited gene. You may not have a family history. The other is that your tumor can be tested, and to see if there are any genetic mutations in your tumor that you've made yourself. Those are called somatic mutations. And that's another discussion to have with Morris. With Michael Morris, if you are having problems with the chemo, it might be advisable to see if there are other alternatives and other drugs that might be good for you. So don't rule out genetic testing just on the basis that you don't have a history. And as Bill has rightly said, we've got people on this call right now who didn't think they had a family history and found mutations. So it's really good advice that you're getting from a very well respected and senior researcher there. Bill, back to you.
Okay, thanks for reminding me about somatic mutations, Rick. Yeah, that's a good recommendation, Mark, for that too. And I also, as a cancer scientist, I think I can point out to you that I hope you don't get too discouraged, because there are so many therapeutic strategies coming down the pike all the time that are turning out to be quite effective, other than chemotherapy or combined with chemotherapy. So it's I hope you can keep that in mind too.
Rick,
Okay.
Barbara was trying to ask something.
Oh, okay. Go ahead, Barbara.
Yeah, I don't know if you can hear me. I don't.
Yes, I can.
Genetic testing. We do have a son. So does that have implications for him too?
I can't really understand you, Barbara.
Okay, we have a son, and I'm just trying to understand if this has implications for him too, if there is a genetic component.
It would if it was in Mark's germline, but not for mutations that are found in the tumor itself, because those are not inherited mutations. But if it was found that he had a mutation in his germline, then yes, it would be a good idea to have your son tested. I have two daughters who have been tested, and both have been found to have that mutation, and that makes a huge difference in how they plan their lives going forward. Okay,
and I would just add to that yes, there is a higher risk. We know that there is a higher risk even without testing for offspring if you have prostate cancer, that a small have prostate cancer. So your son should be certainly I'm very much aware that he needs to start monitoring at a younger age. Probably it's, I don't know how old he is, but probably even getting a baseline at age 35. Yes.
Yeah, that's another good, very good suggestion that I endorse. Okay, so I on April 21st, I had a intrathecal pain pump installed. So this is a hockey puck size device that's implanted underneath my skin in my back, and there's a catheter that goes from the pump into my spine and provides a steady dose of narcotics, a mix of Dilaudid and something called bupivacaine and another one called clonidine. And the reason why I had this was because I had not to deal with pain from metastatic lesions, but rather pain that developed as a consequence of radiation therapy. And because of the mutation that I have, I'm very likely the radiation treatment that I also had caused much more damage than is usually the case in my pelvic region. So I've had a history of acute pain for the last couple of years since a couple of months after radiation treatment ended. And the pump has been extremely effective from the minute that I woke up from the surgery. I have had very little pain, which has been fantastic. It really, this is a game changer. But it came with some complications that neither my doctors nor I expected. So if anyone else is thinking or considering having one of these pumps installed, and that's something that I would recommend to anyone that has pain from the lower spine down, it's something worth considering, including metastatic lesions. These pumps are not able to deliver pain medications higher up in the spine. So if you have painful mets in your thorax region, for example, it's not going to really help there. But below that region, it's likely to provide a great deal of relief. So these things, the pumps require refilling. In my case, because of the dose that they establish about once every month, I have to go into the pain clinic at the cancer center where I work, and they inject do this, and we'll have the pain clinics that have the doctors that have the expertise to install them and to monitor you and to refill the pumps over time. So I think that's it. If anybody has any questions, I'd be happy to answer them, and that includes in the future. If you want to email me, I'd be happy to talk to you about it by email or by phone.
Hey, Mark, how long after the radiation did the pain present?
Can you hear me?
Yes.
So you asked me how long what?
How long after the radiation did the pain start?
Well, the radiation lasted 2 weeks. And I think right at the very end of it, I tried to swallow something in the morning, and it was just like someone stabbed me in the chest. And then moments later, someone else stabbed me in the back. So it began at the very end of the, probably like the day after the whole thing ended, day after my last radiation.
So who was talking about the hockey-sized puck pain, drip?
That was me, Bill Burhans.
Bill, I'm sorry, so I got it wrong. I apologize. The question was for Bill. I'm sorry, Mark. Bill, how long after the radiation did you start getting the pain?
About 4 months, which was quite early. That's not typical.
You said that's not typical?
Yeah, that's correct.
What is typical?
I think more typically it's a year to 2 or even more. The onset of pain can be even 10 years later.
Okay.
Bill, is this pump valve safe? Can it overdose you, or do you have any control over the dosage?
No, there is no patient control over the dose. The physicians can regulate the dose by telemetry. They have devices that communicate with a pump by radio waves, but patients don't have that capability. And there was another part of your question.
Is it fail safe? Is it possible for the pump to fail and overdose you?
No, that's not possible. What has happened occasionally is that the physician who is filling the pump will miss the pump and inject the narcotics into the tissue next to the pump, which is not good. I don't think there are a couple of instances. These pumps have been installed in hundreds of thousands of patients, not just cancer patients, but patients with many other diseases. And I think this has happened only a half dozen times. So it's not something that I'm concerned about. And I should also say that part of the strategy that we use to mitigate the side effects that developed after the pump was installed included dialing down the dose of medications to a level where they weren't impacting my nervous system that controls the muscles in my legs as much as they were initially.
Okay. So if no one else has any questions for Bill, I unfortunately missed, because I'm having problems here with the connection, so I missed a fair amount of what you said, but I'll give you a call a little bit later anyway.
Okay. Yeah, I can see your message, your chat message, so that's fine. The connection to you has been particularly bad for some reason this evening. Perhaps if you turn off your video, you might have a more consistently
I'm doing
strong.
right now, and we'll see if that makes it any better. I don't know why the connection is so rough today, but I'm having a lot of problems.
Okay. I apologize. I wanted to be present for the entire session this evening, but I can't. I have to go. But I'll be back on Monday.
Okay.
So good night, everybody. Does anyone else have any more questions?
I have a quick question for Bill.
Sure.
What was the dose of radiation you had, and yeah, what was the protocol? Briefly.
So the dose was 87 grays. No, sorry, I misspoke. It was 81.7 grays. So a little bit less, but that's still a very high dose.
Yeah.
And it was standard, IMRT that I think most people get these days. And, it was the amount of damage that was done. This is something Rick and I have talked about in the past. For someone who has a mutation in similar to the one that I do, it's a BRCA2 mutation. So the BRCA2 gene is gene is more frequently associated with ovarian and breast cancer.
Right. And
the BRCA2 protein functions in DNA repair pathways. So, so anyone who has a mutation in this gene or related genes is radiosensitive, meaning that, we're sensitive to radiation more than anybody else. And almost certainly what happened to me was that because I didn't get tested until after radiation treatment, unfortunately. Otherwise, we would have dialed down the dose of radiation. But because I didn't know, we went ahead with that high dose, and it caused more damage than normally would be the case for someone without that mutation. But I don't, I don't want anybody who might be listening who is getting ready to have radiation treatment to think that this is a typical experience. It's not. It's more common, I think, if for those of us that have the mutation. But if you don't have the mutation, it's not something you need to worry about.
Okay. Thank you.
Okay. Anyone else?
Thanks a lot, Bill.
Sure. Okay. I will talk to you guys next week.
Take care, Bill. Rick, I have a comment for Mark. It's okay. Can you hear me?
Yeah.
I'm listening.
You mentioned pain after your chemotherapy. Is it associated with your with the Neulasta, do you think?
Was it associated with what?
Are you taking Neulasta after your chemotherapy, correct?
No.
Oh, I thought you said earlier that you were.
No, that was
No.
Okay. And never mind, I don't have a comment.
Okay.
Jeff Dreyer.
Yeah, I have to sign off now. I have this meeting in about 2 minutes. So sorry. I'll join next week. Thanks a lot. Bye.
So let's see. Eric. Are you with us, Eric?
There I am.
Go ahead.
I was just out in the sun trying to warm up. I got really chilled.
Oh dear. Okay. Eric, you need a cup of coffee in that Harrods mug.
Yeah, there you go. That's a nice mug. Got it right on my dresser. Colors match.
There you go. Okay.
So I started to go into it about how I was having a lot of pain in my right arm, the underneath part of the arm, all the way down to the little finger and ring finger, and across the back. Sometimes in my left, but mostly in my right.
And as I say, then they finally did the MRI and found the cancer. And they said that the reason they only did 5 treatments instead of the 10 they did the other 2 times was because they had already been radiating in that area and didn't want to overlap and give me too much, kill off all the good cells. I still get a lot of pain. Take Norco and OxyContin for it. I'm going back to San Francisco to UCSF. They're obviously going to discontinue the GS 5928, and he said he was going to go with Xofigo. I don't know. He may have changed his mind by the time I get back there, but that was the plan, was to go with Xofigo. I'd be interested if anyone else has had Xofigo and what experiences they've had with it, whether it helped or not. I have the feeling that this is one of those, it helps in 20% of the cases or something like that. I used the same mask for those of you that haven't had this kind of radiation. They put a mask, they make this mask out of plastic that heats up and push it down over you. And so when you're having the radiation done, this mask goes from the top of your head to the middle of your abdomen, and it's to hold you still so that they can aim more carefully. And each time, and it took a lot longer this time than before because, again, they were trying to be so exact. So they put it down, got out of the room, took some x-rays, moved the machine around, took some x-rays from another angle. They did that a couple of times, and then they evaluate. And if they decide they have to move the table, they have a motor that moves the table, a 1/16 of an inch or something like that. And then if they have to move it, then they'll start all over with the x-rays. So the actual radiation is 2 doses about 1.5 minutes each, but the whole process takes about 40 minutes. And so I'm lying there with this mask. Now, I brought my mask. They gave the mask to me, and that's just the 3rd time I've had it done. I brought it back for the 2nd, and it was okay. And they used it again this time. And it's only 5 sessions, so I let it go, but it was really tight. I put on enough weight that the mask was really tight across my face. I would leave with a waffle impression on my face. But I'm hoping that it's going to have some effect. As I say, the pain's still coming. I don't know, but I guess the answer, if this doesn't get rid of the pain, is just continue taking lots of narcotics. I don't, that's where I am right now. I take 4 or 5 Norcos a day and 6 or 8 OxyContins.
Jeez. Eric, have you noticed any difference since you had the 5 sessions?
Well, I told you the first thing I noticed was that it got much worse. And then when they gave me the prednisone, or the methylprednisone, it got better, but it got better enough that I could treat it with the Norco and the OxyContin, whereas before the pain was so bad that those didn't even do anything to it. So yes, it's gotten better. I remember when I had it before, it was really 2 weeks before the full effect was felt. So I'm hoping that it'll get better in the next 2 weeks. So let's see, I don't have anything else to say about it.
Anybody else to talk to Eric about this latest procedure? No?
Eric, do you feel this this other drug they put you on, did that give you any positive results? This GS 59, whatever it is?
Well, yeah, it kept my tumors in check for almost 10 months.
Okay.
So, which was better than the Zytiga. Is that what it is? I've lost track now. That only worked for a couple of months. So my PSA went up to 16 or something like that. And the last time they checked it, it was down around 12. So it went back down a little bit. But the whole time I was on the GS 5829, my PSA kept going up.
I'm just looking, I don't know that anybody on this call has done the radium-223. I mean, the closest we would come is Paul Hobson, who's going through his lutetium treatment. Just before I go, has anybody done radium-223? Am I missing something? I mean, we've had a lot of guys that do radium-223, and my own anecdotal impression is that it's got a better strike rate than 20%. I mean, most people seem to see, especially for pain, they seem to feel that it's helped them. You know, we always say, because I think it's really important, just be very careful that your blood counts are healthy before you start, because if they're not, you can have significant issues. But we've got a lot of people, so if you would like to speak to people that have done it, then I recommend let me know and I can put you in contact. I mean, Dr. Steve is probably the most recent guy. He's in Hawaii this week, or in Kauai. But I can certainly put you in touch with people that have done it, Eric.
Okay, I would appreciate that.
Okay, I'll make a note and I'll do that. Okay.
Yeah, I go back to UCSF on Monday, so that's when I'll find out what it is that's going to go on.
Right. I've just made a note, and we'll come up with some. I'll come up with 2 or 3 people that have done it, and I'll send them an email afterwards for you, and then they'll get back to you, I'm sure. Anybody else have any observations for Eric regarding radium-223 Zytiga? Paul, how are you doing your lutetium treatment?
I've had the 4th treatment now. That was about a month, 5 weeks ago. Mm-hmm. I was talking to some of the doctors doing the trial. It's a small phase 1, phase 2 trial that has only got 30 people on it. About their results so far, and they're going to present these at the European Oncology Conference, whatever it is, at ESCO in Barcelona in September. 70% of the people had PSA drops of greater than 50%. And then about 37% had drops of greater than 80%. So some quite spectacular results with the lutetium, and I think all the research team's expecting that once they publish these, talk about these results at ESCO, that there'll be a lot more interest in lutetium. From my own point of view, I haven't been in the fantastic results thing. I've had mixed results. It has, though, stabilised and stopped the cancer from progressing. So at the moment, I'm about 4 weeks off from under the protocol, having a whole lot of imaging and so on, where they'll assess the effect of the treatment they've given me, and possibly look at giving me a further lutetium infusion. So that's my news at the moment.
Okay, so just for those of you who aren't clear about what this lutetium is, it's very similar to, it's a similar process to the Zytiga, in that it's a nano radionuclide agent that is infused and then goes to is attracted to a certain place. The difference is that the Zytiga, the radium-223, is attracted to bone, to calcium, all calcium, and this agent that Paul is using is attracted to prostate-specific membrane antigen, which is an antigen, a protein that is on the surface of all prostate cells, as well as a few other cells that are not prostate-related. So it's much more specific, and the lutetium is a radioactive agent. So what we would expect is that it would work as well, if not better, than the radium, and it would have less side effects. It wouldn't cause the same level of side effects. Is that a fair summary, Paul, or would you want to add anything to that?
No, it is indeed, but one of the main benefits over the radium-223 is that rather than just being bone, it will also do prostate cancer in soft tissue.
Right.
So much more extensive than Zytiga.
Right.
But compared with chemotherapy and so on, the side effects are very few. So it's quite effective in sort of knocking the cancer, but with relatively few side effects. So they're very enthusiastic about it.
How's your general recovery, Paul? How's your mobility issues? Any change in the last couple of weeks?
There's not going to be any change in my mobility issues, thanks, Rick. Yeah, I'm in a situation where my ability to walk is limited. I have to, I get round in a sort of an electric wheelchair. I find that after a few hours in the electric wheelchair, my back gets very sore and painful, so I'm a bit limited with that.
Mm-hmm.
But generally getting on okay.
Okay. Anybody like to chat with Paul who's on the line? Offer condolences regarding the Australian cricket team, maybe? I got no takers.
Australia has been, their national soccer team played Brazil last night and went down 4-0, so we'd better avoid sport of any kind, I think.
How those Wallabies doing?
Oh, haven't looked.
Okay. By the way, Paul, and you might make a note of this on your advanced cancer blog in Australia. I don't think we had the telephone line set up right for people that wanted to come in on the telephone from Australia. It is now set up correctly. So if people don't want to come in on the internet, but they want to call in the number that we provide, it should now work. I figured that all out this morning. So
well, the fact that you're talking to me suggests that it might work.
Oh, okay. Well, they told me, I know you've called in before, but they told me it wouldn't work. I had to authorize something in my settings, which I did, but I'm glad to hear it works. That's excellent. You're coming to...
I've been calling in on the same number for months, and
there you go. I think we know more than GoToMeeting does sometimes. They confuse us. All right, let's move on to Peter and let's discuss a little bit and just open it up. Most of you have heard that there was some fairly revolutionary news at ASCO last week regarding the early use of abiraterone acetate or Zytiga. And it included two different studies, one called the STAMPEDE study, which is out of the UK, and another called the LATITUDE study. And both of them really, and of course this was coordinated at ASCO so that one study endorsed the other. And what I'd like to do, and I haven't asked Peter if he's ready to do this, but I have a few notes here, but I want to just go back to Peter since he raised it. Last week, we were all caught a little unawares or with our trousers down because we haven't really looked at the studies. I know I have. I suspect Peter has. Peter, do you want to talk a little bit about this this abiraterone Zytiga issue and the relevance to some of the guys that call in to this call, that participate in this call?
Right. I reread the study a couple of times. It's still a little bit confusing to me, but it seems to give the impression that with some trials they found out that there's a substantial benefit to taking Zytiga along with Lupron early rather than just the Lupron. I think that was the study. They did Zytiga plus Lupron and Lupron alone, and they found that they had a substantial increase in longevity and length of time before any kind of progression of disease. So enough that they had very encouraging results for it. So I guess my question is, because like a year ago or so, there were studies out that gave the same impression that early chemo along with Lupron at the beginning of diagnosis had a good effect as well. So I'm not sure, it's confusing to me which way to go, and whether there's a number of things. Then it opens up the question also in my mind, if they only did Zytiga, is it true with Xtandi as well, or just Zytiga? Maybe they haven't funded that study yet. So I'm a little bit confused over this stuff, and I guess they haven't really approved this for as a treatment, but they seem to be pretty encouraged by it. But
this is Dave Hallward speaking. I'd like to talk a little bit about my experience, because I've obviously have had docetaxel, and then I had Xtandi, not Zytiga. I was looking at Xtandi, but it's fairly early, and I can just quickly go through it and see how my physicians approached it. So, and whether that, I appear to be hopefully a successful thing. I was diagnosed about 9 years ago with Gleason 9 prostate cancer. Had a prostatectomy, followed up with, after 6 months, went to 38 radiation treatments. That was back in 2000 early, all of 2009 with it. And then what happened is recurrence happened in 2011. And I was not on any hormones except for during radiation, no Lupron. Went up, my PSA rose from, within about a year, approximately a year, maybe about 8 months, in 2011 up to pelvic lymph node dissection of 20 cancerous lymph nodes in the pelvis. Followed up with 1 year and so it went up to 11.6, dropped down. During 2013, I was on Lupron Casodex the entire year, and then it proceeded to climb from the middle of 2014 to January of 2015 up to 34.6. They saw chest mets, and they removed 12 metastasized lymph nodes in the chest. It only dropped to 32.4. That the Taxol went in. I did 9 treatments. The docetaxel was dropping 40% per treatment across the time frame, and after 9 treatments, then I proceeded to start with Xtandi for 1 year and hormone therapy for at the same time. And now I have been on hormone therapy on Lupron for 2 years. I just did the Xtandi for, basically 1 year, and it's been undetectable for 2 years. So that was my experience, and I don't know if that's early or not. I don't know, but I did experience chemo up front, and I did not have hormone-resistant prostate cancer that I am aware of, but that's happened to me. So I was.
You are pretty much.
Go ahead.
Sweet spot of the men that were in both the Stampede and the Latitude trial. I mean,
Oh, really? Okay, so I'm falling in that category. So I didn't know. So that's why I figured I'd throw it out there.
My reading of the trial is that the Stampede trial, 52% of the men had metastasized disease. 28% of the men metastasized to the bone, that is. 28% of the men had disease in the lymph system, and 20% of the men were not metastatic. So a large number of these men who got chemotherapy, who got abiraterone early, had advanced disease, and they were all still castrate sensitive, meaning they still responded to whatever LHRH drug they were taking, Lupron or Zoladex or Trelstar or Phonogon, whatever it was. And there were 2 arms to the study. One was people that just continued with their straight old ADT, androgen deprivation therapy, their LHRH drug. And the other side were men who had abiraterone, who got abiraterone and prednisone, which is taken with the abiraterone usually, as well as their hormone therapy. There is, just as an aside, a very similar trial going on with enzalutamide. And last Friday, the people at Pfizer Medivation reduced their endpoint from 1,500 and something, 60 odd, I think, participants to 1,400 participants, and which they've reached. So they can now start to close out the trial and publish results, which they're planning on doing in September. So it sounds to me that like that Medivation is anxious to publish results. Probably they are as good as abiraterone. I don't know for a fact, but that's the impression. That's the impression I'm getting. The other study was the Latitude study, which was a study designed with a 30-month follow-up. And that had fewer patients. It had 1,200. I'm just rounding the numbers, 1,200 versus about 1,900. And that had better endpoints. In other words, what it was measuring was easier for us as patients to understand. The first study, the Stampede study, it found the following. It found that in the group that had ADT alone, there were 262 people that died. Not clear to me. I'd have to go in and look, and maybe somebody can do it, whether that was prostate specific or whether that was all-purpose death. I think it was all-purpose. And there were 184 people that died in the abiraterone arm. There were 535 people in the androgen deprivation therapy arm that failed androgen deprivation. In other words, they progressed. There were only 248 people that failed ADT in the arm where abiraterone was taken. So what it's also telling us there is that you take abiraterone with ADT, you stay hormone sensitive quite a bit longer. And then lastly, they observed that the more adverse side effects, what they call grade 3 to grade 5 side effects, which are sort of relatively more intermediate to serious side effects, there were only 33% in the ADT, but there were 47% if you were taking abiraterone as well. So the abiraterone and the ADT did cause more side effects, but it also had better results. Now, what we want to know is, well, what difference does it make in terms of overall survival? And I actually had the chance to speak to Pfizer last week, Medivation Pfizer, about a new study that they are putting together, because I had made a big stink earlier on in the year about the fact that their old prospect study, some of you may remember, was just badly worded, badly defined, a poor website. And fortunately, they heard me well enough that they're now getting patient input before they put out this next study. And one of the things I said to them is, however, whatever study you put out, make sure there's a measure of overall survival, because that's what the guys look for first. It may not be the most important thing in some studies. Pain-free survival may be more important, and non-progression from your standpoint. But the guys want to know, is it going to make a difference for how long I'm going to be around? What they found in the Latitude study was that, and I'm not quite sure how they did this, because they talk about 30-month follow-up, but that amongst the 1,200 patients, the overall survival for these people that were also hormone sensitive when they got the drug, when they got the abiraterone and prednisone, for men on ADT alone, 34.7 months was what they measured as overall survival. So it was longer than the follow-up period. Not sure quite why. Maybe because some people, they were following each person for 30 months and they got people over a period of time, so they were able to find people, follow some people for longer. I'm not sure, but it was 34.7. In those that were taking ADT plus abiraterone, they haven't been able to determine, they haven't reached out long enough to say what the follow-up period is. In other words, not enough people have passed away, so they know that it's longer than 30 months. They just don't know how much longer than 30 months. So that tells us that you're better off with adding the abiraterone to the Lupron or whatever LHRH drug you're taking than not. The other thing they measured was radiographic-free progression, meaning once you start taking the drug, how long is it before you need more radiation? And for men who were on ADT, that was 15 months, 14.8 months. For men that were on ADT and abiraterone, it was 30 months. So it doubled the length of time you can go before you need any additional radiation. So those were the two studies, and that's what everybody's talking about. And now the question is, as somebody said, I think Peter at the beginning, well, what difference would it make if you took abiraterone and chemotherapy? And they're actually measuring that in the STAMPEDE trial this is this big trial in London out of Royal Marsden and the National Health Institute there. And they have an arm in this STAMPEDE trial that is looking at abiraterone plus chemotherapy, but they're not ready to publish the results yet. I don't know what's going on with enzalutamide Xtandi plus chemotherapy, but I can find out. I can ask. But I guess what we're deducing from this is that when you add these second-line anti-androgens early in the disease cycle, they make a huge difference. I mean, we know that ourselves intimately here because Rob Boniscus, God bless him, has gotten, because he's now moved on to other drugs, but he got 4.5 years out of abiraterone. He was on an early trial with abiraterone, and he did exceptionally well with it for a long period of time. And so he was sort of their poster boy, to the extent that they actually made a poster of him with the video. Some of you have seen these videos of Rob. If you haven't, you can find them on our website, or you can go to Janssen's site and what's it called? My prostate cancer, I think it's called, or my prostate cancer plan. You can see a whole bunch of videos on that they made of Rob and another guy. And you know, it really is, it's really encouraging. Now, what's also interesting is that abiraterone is supposed to go generic within a year. So once abiraterone goes generic, it's going to be much less expensive to access that drug. And I suspect what we're going to see is a lot of medical oncologists putting their men onto abiraterone much earlier. I mean, right now, it's kind of hard, I think, to get your insurance company to approve abiraterone until you're clearly metastatic. So all these people that are experimenting with abiraterone before they're metastatic are all doing it through trials, unless they can convince their insurance company, or they're wealthy enough that they can pay for it, because abiraterone runs about $8,000 a month. But that's all going to change very soon. So they're great results, and maybe even game-changing, because they're going to push chemotherapy off even more. But again, we know that chemo, depending on who you're talking to, has somewhere between 14 to 22 months, adds somewhere between 14 to 20 months to overall survival, based on which of the 3 trials you're looking at for chemo. We can't tell you what either abiraterone or enzalutamide does, but it looks pretty optimistic. And that's really what everybody wants to know. Well, should I do the chemo because I know what that's going to do, or should I do abiraterone, or should I do them both? Doing them both may be too hard on the system. I mean, I remember when radium-223 first came out, people said, well, should we do radium-223 and chemotherapy at the same time? And there were trials. And Jerry Carniglia, God rest his soul, did it at the same time, and it was just too hard on his system. And it basically killed him. So, you know, we don't know how smart it is to mix and match. That's what trials are all about. And who knows what might happen.
Rick?
Yeah.
Rick, one of the questions in my mind that it opens up is, what happens what happens when you take these second-line drugs with radiation? I mean, right now, it's suggested that you go on hormone treatment for radiation. You know, maybe they need to do studies of the effect of abiraterone or enzalutamide with radiation as well. That would be interesting.
Well, I mean, I think there are. Have you looked at under clinicaltrials.gov to see whether there are any trials with radiation and enzalutamide?
No, not yet. No, this just came to my mind as you were talking with this stuff.
I think there are. I think I might have seen it. I don't bring any to mind right off the bat, and I don't want to play around and look at the same time on this silly little
No,
tab.
that's okay. I'm just speaking. I'm just talking out loud off the top of my head because it brings up a lot of different options and suggestions and thoughts.
So
Hey, and Rick,
yeah,
it's Don Price.
I can hear. I got you.
Okay. Before you take it as accepted fact that insurance companies do not pay for Zytiga prior to the cancer being metastatic, just as a reminder, mine did pay for Zytiga, right when I started, in my case, Firmagon, before it was metastatic. So not all insurance companies may do what you just said. They may pay for it, but well, mine did. So.
Right. I didn't say they would not. I mean, I know that in some instances they don't, but some insurance companies will. Who was your insurer, Tom?
Well, it was a government program for military called TRICARE.
Okay. Yeah, I'm familiar with TRICARE.
This is Dave speaking. Mine, they paid for Taxotere up front, followed with Xtandi. I know it was in a month. So, and they took care of both of them.
So your insurers paid for the Taxotere, and then they did pay for the Xtandi?
Correct. Yeah, but it was Taxotere first, and then Xtandi after that.
Right.
And I could have gone Zytiga. It's just that my medical oncologist said that in his mind, Xtandi had a more durable response, and that's obviously his take.
At what stage were you identified with bone mets?
I'd had no bone mets. I had taken chest mets. I had 12 chest lymph nodes taken out of the chest, but the PSA didn't drop after that surgical intervention. So then I went on chemotherapy at 32.6 is when they started the Xtandi. Or no, the tactile.
But didn't you have a met in the sternum at some point?
Yes, the met was in the sternum, and they took the lymph nodes out. That's when they, after that PSA didn't drop following that surgical intervention, that's when they started doxycycline.
Right. So you see, you were okay with the insurance because you had a bone met.
Ah, I see. Okay.
But Don's case is a little different. And again,
well, that was a lymph node. Those are lymph nodes. It was not a bone met. It was lymph nodes.
What was it in the sternum though? The sternum is bone.
It was underneath the sternum. There were lymph nodes underneath the sternum.
Okay. Well, again, they may, because it was identifiable on a lot of lymph nodes, you may have gotten down that because it was clearly metastasized.
Right.
For most people, you have to be able to exhibit clear metastasis, right?
Okay.
But what we're saying is, well, what about giving this when there's no mets or new mets? And Don got it, but I know that there are other men that have wanted to start it early and they haven't been able to get it.
Okay, I see your point.
And
Dave, are you still on Xtandi and ADT, or are you off of everything?
No, I'm off of. I came off Xtandi 2 years ago, in August. So I was on it for a full year.
So are you taking anything at this point?
Lupron.
Lupron, but you're in remission though.
Yeah, absolutely no undetectable for 2 years.
That's a great story. I mean, I salute you. That's an amazing story of what you've been through, and to come out at this point with a remission. I sure hope it's durable.
I know that one of the things that when they started the doxycycline, when the PSA, when there was there was lymph nodes underneath the chest, under the they what happened was that the medical oncologist said this is the perfect timing to start dying, because he says we have a very fast activity right now, so this is the time. And then my response was phenomenal. 40% reduction every treatment. It's just the PSA was just plummeting. Then it got down below 1, and then we started Xtandi.
Wow.
And it went to undetectable almost, really quickly.
Well, I hope that this little discussion has helped clarify a little bit what has been going on with these ASCO, what's been going on at ASCO with respect to abiraterone. Anybody on the call have any questions or want to follow up on on this topic?
Paul Hobson, a question. When people keep talking about abiraterone becoming generic, when's that likely to happen?
I think somebody said to me that it comes, don't quote me, Paul, but I think somebody said to me it comes off in like September or October. But I'm not 100% sure. It's tied into the timing of the patent, I believe, and not the timing of the FDA approval. So I remember back in summer of 2008 hearing about abiraterone for the first time at a presentation at UCSF from Chuck Ryan. And then I'm not sure when it was FDA approved. I think it was 2011 or 2010. But the time that it stays on the patent, I think, the time that it is protected is related to the patent and not the approval, I think, but I'm not sure about that. Does anybody know? No. Anybody want to do some homework to check it out so they can tell us later?
I mentioned this several weeks ago, but there's also a biosimilar to abiraterone coming out. I think it's called Yazgo, something like that.
Right.
That does not apply. The patent rules do not apply because it's a similar drug, but it's not a copy of the drug. So that too will drive prices down.
Right. We had.
Sorry, Rick. I just wonder how willing Janssen will be to, if abiraterone's generic, to keep going with some of the trials in relation to abiraterone.
Yeah, well, I mean, my understanding is that they've got a drug that's more powerful than abiraterone is what they're trialing now. I don't know that for certain. That's what I've been told. The other issue, of course, with Janssen is the fact that now we know that you can take a quarter of the dose with a meal, or half the dose.
So they double the size of a tablet.
Oh, you cynical Aussie, you. Is it half the dose or a quarter of the dose? Somebody remember.
I was a quarter of the dose.
Right, a quarter of the dose. So
one out of 4.
Right. So, if you take a quarter of the dose with the meal, it's just as good as taking 4 times as much. Well, that doesn't really help Janssen. But, the argument is, well, Janssen doesn't care too much at this point because the patent's about to come off the drug. So, did somebody new join us? I see another caller on here. Is somebody that we haven't talked to or acknowledged?
I had to go away, but I came back. This is Sylvester.
Hey, all right. And we know it's you, Sylvester. I thought it might be Ken Anderson sneaking on at the end again. which I don't mind so much when it's 5 p.m. rather than 3:30 a.m. So I could have handled it today. Okay. Anybody else want to say anything about the Zytiga?
No, this is Peter. I just want to ask Mark and Barbara whether this chat has been uplifting for them and given them more encouragement to fight on and look for other options, or how do you feel about it?
Sorry. Did you hear my cough? Do you hear me?
Yeah,
yes.
You're good. We hear you.
Yeah, it was very helpful to see how much longer the lives are extended, and I have a lot of questions now from my doctor that might make the treatment easier. But I still got to make a hard call here. I mean, but even when you guys say that you endured something terrible and you're glad you did it and you beat the odds, it just sounded hellish at times. Maybe I'm just being a weenie, but if there's a way to ease this after effects of chemo and just to make it just so you're not living from one hellish period to another, just waiting for the next chemo. Right. I just can't see that.
So, you know, Mark, what I thank God have never had to do chemo. I was willing to do it when I was diagnosed, but it wasn't deemed appropriate. But most of the guys that I talk to break it down over a 3-week period into the following, which I think is what you're seeing. Is for the 5 days or so right around the chemo, they don't feel too bad because they're getting high doses of steroids. They're getting prednisone, and then they get a bunch of dexamethasone on the day of chemo, and they feel pretty good for 2 or 3 days. Then on the they have probably about 10 rough days, and then they have 5 good days, and then they get back into that cycle again. So what you're experiencing is pretty typical. It doesn't make it easier to deal with, but you should know that it is pretty typical. Now, there are some things you mentioned that I haven't heard before, like the issue around your esophagus, for example.
That's because one chemo got interrupted by a 2-week radiation session that's burned the hell out of my esophagus.
Okay. And you know, that's sort of interesting because that sort of gets into this discussion about combining radiation with other drugs. But having said all of that, there are some good options. I mean, definitely talk to Morris about a slightly lower dose, and talk to him about cabazitaxel, and talk to him about some of these other drugs we've mentioned today that might help you with some of the side effects. Because
yes, and the genetic thing is interesting too.
Right, and the genetic thing, and you know, maybe talk to him about trying early immediate use of abiraterone or enzalutamide. I mean, the one thing we haven't talked about today with abiraterone and enzalutamide, and just want to remind everybody, 35% of men fail abiraterone and enzalutamide. So it's not a sure thing. There's a lot of people that carry a mutation, which means they don't get anything out of it. So
I was in a trial and was on abiraterone.
And
sure, because it was. I don't know if it made much of a difference. I was on abiraterone and a mystery drug, so we didn't know if we were
right
on the sugar cube or not.
Well, you know, one thing to talk to Michael Morris about is to just check to run an ARV7 test and see if you are receptive to abiraterone and enzalutamide. Because at least that way we know whether you're a candidate for those drugs or you're not. You may not be a candidate for those drugs. So Anyway, look, we hope that both of you will come back onto this call. We hope Barbara will come onto the Caregivers call, and we hope we'll have the opportunity to support you.
Well, thank you very much. You guys have been a welcome resource.
Good. Well, that's what we're here for. And everybody, again, you know, the pitch that I try to make each time, sometimes I have to go onto Peter's call to make the pitch too, is that just don't forget us when with Amazon Smile. Sign up for Amazon Smile. It doesn't cost you anything. And don't forget us in your charitable giving plans, because we're a 501c3. We're looking to expand. We're looking to bring on more moderators. And not everybody will do it just for the love of doing it. We have to, we're having to start to think about how we compensate moderators, if not for prostate cancer, for some of the other diseases. So please support AnCan. Okay, anything else tonight?
Hey, Rick, it's Dennis.
Yes, Dennis.
I had one question about genetic testing, and I think Bill Burhans has left, hasn't he?
Yes, he has. Tell me.
Yeah, I was, you know, a few years back, I was doing some genealogy stuff. I've forgotten all about it. Relative to having, you know, Foundation One or somebody do the genetic germline testing for the genes like the BRCA2. And at the time, I had very little information other than that all of the males on my father's side of the family were, you know, dying in their 60s.
Right.
My father died at 61 from lung cancer from smoking.
Right.
But I did find his brother died at 69 from prostate cancer.
Right.
So I don't know, you know, if my father actually died with prostate cancer, not knowing it.
Right.
And with that makes me a little more likely to possibly be a carrier of that gene or one of the others that.
Well,
and whether or not it's, you know, at my point here, is it too late for this type of a test for my treatment? Would it change my treatment ongoing here, or is it too early to have this test done?
Okay, so again, we have to separate. We have to separate the inherited test, which is called the germline test,
right,
from the somatic test, which are the changes you're making yourself in your tumor.
Right.
You may be a good candidate for a germline test, which is what Peter did just recently. And Peter found that he was a carrier of a mutation that is associated with Lynch syndrome, which is usually more in line with colorectal disease, but is also associated with some other cancers, with pancreatic and with sometimes with prostate and I think even with lung. So it definitely makes sense, especially if you have kids. You have kids, don't you, Dennis?
Yeah, 2 daughters.
So it is important because your daughters have a right to know whether there's a possibility that they would have a gene mutation, because it would affect what they need to monitor.
Right.
And if you have a prevalence of cancer for any reason, it's probably smart to get a germline test. In most cases now, if you've got decent physicians, they can find ways to get it covered. Medicare will cover it under certain circumstances. You know, if you've got a father that died of cancer, a brother that died of cancer, it's probably enough that they'll do a germline test for you. You wait, 3 or 4 weeks. I don't know, you spit into a bottle or they take a blood sample and then they'll come back and they'll tell you. That's one thing. The other is, what about your actual tumor? Has it mutated? And it may have done. Either of those 2 conditions can indicate a drug. So for Bill Burhans, when he because he had a lot of cancer in his family, when he did his inherited test, he found out that he was BRCA positive. He had BRCA2. And that identified a drug, happened to be a drug he was actually working on, ironically, called olaparib. And he started taking it, and it's melted most of his tumors away. Now, had he known that he was BRCA positive earlier on in the disease cycle, he would have had a lot less radiation. And they may have made other adjustments, and he wouldn't be going through some of the side effects he's going through right now. So
Right.
I think it makes sense to consider both a germline test, and maybe not just yet for the tumor test, because you seem to be doing well on the treatment that you've had, but at some point a test on your tumor as well.
Yeah. Okay. That's kind of what I was figuring.
Peter.
And the other question I was going to ask him, if he knew, you know, if it's genetic, is it always an early age diagnosis? He mentioned that with that gene, that's typically people diagnosed at a fairly early age.
Yeah, I don't know, but I do know that if you send him an email, I'll make a note to send you his email address.
Okay.
And he will. He's a prince in terms of responding. He'll get back to you, and you can send him an email, ask him the question. He'll get back to you without any question of a doubt.
Yeah.
Okay.
Okay. Yep.
Peter, did you want to add anything on the genetic side since you've just been through this?
Yeah, just Dennis, start gathering all your information. That's probably true with anybody. Just start making notes of family history with cancers. Write it down before people die, or before your great aunt dies. Try to track all this stuff down, because they'll ask you, and the better your family tree on both sides of your family is, the more accurate it is, the better your chances of getting insurance to cover this test. And also your latter question about, I think my impression was Bill said that when the younger people come down, people in their 40s or so with prostate cancer, there's a good likelihood that there's some kind of genetic mutation. But there's no hard and fast rule. Those of us who get diagnosed in our 60s could well have a genetic mutation too. I mean, it seems like with prostate cancer, there's no rules. The only one I can think of is likely to affect men much more than women.
Gotcha. Okay.
All right, gents and ladies. We're going to call it a day right now. I will try and get this call posted onto the internet. There are going to be some gaps in it, I'm afraid, because of my computer. But standing, I'll put it up there, and you'll just have to bear with it. So that's it. Next call next Monday night at 8 o'clock Eastern, 5 o'clock Pacific.
You didn't say, Rick, you didn't say anything about the Warriors. You just talked about cricket.
You're right. Go Warriors.
Go Warriors.
Go Warriors. What can I say? I'm very happy for Kevin Durant. Yeah. Okay. Go Warriors.
Bye-bye.
All right, guys.
Goodbye.
Good night.
Thank you.
Pleasure.